the basic investigation involves blood investigation like hematological investigation, CBP, hematocrit, amylase lipase, and other investigation like ABG, chest X-ray, and ultrasound of abdomen. I was discussing about the investigation. We do ultrasound to diagnose primarily to see the pancreatic gland, whether it's a edematous or non-edematous. We see the duct size, whether the duct is dilated, any calcification is there or not. The other finding which we can get on ultrasound is we can know about the gallstone, which is primarily the commonest cause of acute pancreatitis. Apart from that, we get a chest X-ray done to know the effusion is there, because if there is a fluid accumulation in the chest, we call it as severe acute pancreatitis. So I described the list of investigation: hematological investigation, radiological investigation. Third is in radiological role of CT. We usually do CT in severe cases, because in mild acute pancreatitis we don't need CT scan. It is diagnosed by clinical means. As far as severe acute pancreatitis is concerned, we diagnose severe acute pancreatitis by doing a CT scan 72 hours after the onset of abdominal pain, because by then we get clear idea about the necrosis and non-necrosis of pancreatitis. So when it is a necrotizing acute pancreatitis which is picked up on a CT scan, the prognosis of the patient is usually decided by the score of necrosis in a setting of acute pancreatitis. Other investigations are primarily focused on the etiology, like evaluation of calcium, lipid profile. Then we go into the details of autoimmune workup, IgG4 and other autoimmune markers we need to do. Also, we need to go into details of the drug history or trauma and other causes for diagnosing the acute pancreatitis. One of the important investigation in a setting of an acute pancreatitis, apart from hematological and radiological, as I discussed, ultrasound and CT scan of abdomen. Third investigation, an MRI of abdomen or MRCP to know the pancreatic ductal anatomy, especially in setting of pancreas divisum. Now we also have an endoscopic ultrasound, which is the gold standard for diagnosing the patients with microlithiasis or gallstone related pancreatitis. As well, pancreatic collection and then treating the pancreatic collection in a setting of acute pancreatitis. ERCP in a setting of acute pancreatitis is reserved for ductal disruptions like traumatic cause, where there is a ductal disruption. In those cases of acute pancreatitis, ERCP plays a vital role. Even in patients of gallstone pancreatitis, in first 72 hours, ERCP and sphincterotomy has been proved to be beneficial in patients of acute pancreatitis.